Okay, let's jump right into this essential explainer of the newly updated RCOG Green-top Guideline No. 51, specifically focusing on managing monochorionic twin pregnancies. If you're dealing with multiple pregnancies, you already know the stakes are incredibly high, but this 2024 update brings some absolutely critical, practice-changing nuances to the table that we have to cover today. So, if you're an MRCOG candidate or a clinical professional, listen up. We are going to zero in heavily on exactly what has changed in 2024. These are the high-yield facts you literally need for your exams and, even more importantly, for your ward rounds and clinical decision-making. The whole landscape of fetal surveillance is evolving fast, and staying updated isn't just a good idea. It's completely non-negotiable for delivering top-tier care. We are going to unlock the new standards that directly dictate the survival and health of these high-risk pregnancies. We're talking massive shifts in aneuploidy screening, incredibly strict new definitions for selective growth restriction, brand new routine screening protocols for TAPS, and updated surgical mandates for twin-to-twin transfusion syndrome. It's a lot, but we'll break it down. Here is our exact clinical roadmap for today. 1. Diagnosis and baseline risks. 2. Routine screening and ultrasound. 3. Detecting specific fetal complications. 4. Managing complex twin pathologies. And finally, 5. Timing and mode of birth. Section 1. Diagnosis and baseline risks. The critical first trimester window. The golden rule here is all about timing. Chorionicity absolutely must be determined before 14 weeks using the T sign and the number of placental masses. But here is a highly testable new 2024 rule. You are now officially required to retain an electronic or photographic record of this membrane attachment permanently linked to the patient's records. Why? Because we all know that sheer panic of uncertainty later in the third trimester. That archived image is going to be your lifeline. And hey, if any doubt remains at this early stage, the guideline is crystal clear. Refer the woman to a fetal medicine specialist without delay. The crucial takeaway early on is that a shared placenta literally means shared risks. Because these fetuses have conjoined circulations through vascular anastomoses, they face significantly higher overall fetal loss rates compared to dichorionic twins, alongside a real increased risk of neurodevelopmental morbidity. They're highly susceptible to the big three pathologies: TTTS, TAPS, and sFGR. This specific risk profile has to form the absolute foundation of your parental counseling from day one. Section 2. Routine screening and ultrasound. The new surveillance rhythm.
The 2024 update has really tightened up how we monitor these twins. From 16 weeks, you're locked into doing 2 weekly scans, checking estimated fetal weight, deepest vertical pocket, and umbilical artery pulsatility index. But notice the major update here, the introduction of middle cerebral artery peak systolic velocity, or MCA-PSV, screening starting at 20 weeks. This is huge. Since TAPS can happen spontaneously in about 2% of uncomplicated cases, we are now actively screening for it at every single scan from 20 weeks right up until birth.
And speaking of screening, let's look at aneuploidy. The 2024 update officially gives the green light to cell-free fetal DNA testing, what we often call NIPT, in twin pregnancies. It's now recommended by the UK National Screening Committee, contingent on the results of the first trimester combined test for major autosomal trisomies. It boasts a staggering 99% detection rate for trisomy 21 in twins, which fundamentally upgrades our diagnostic confidence.
Section 3. Detecting specific fetal complications. The big three pathologies.
This is where your diagnostic skills are really put to the test. When contrasting TTTS and TAPS, think of TTTS as a rapid fluid problem caused by volume shifts through mostly unidirectional anastomosis. You diagnose it by seeing a deepest vertical pocket of less than 2 centimeters in the donor and over 8 centimeters or 10 centimeters after 20 weeks in the recipient. TAPS, on the flip side, is a slow, sneaky blood transfusion issue driven by minuscule anastomosis, completely without those massive fluid differences. You catch TOPS by spotting that MCA-PSV discordance, specifically signs of anemia in the donor and polycythaemia in the recipient.
I want you to lock the number 4 into your brain right now. A brand new 2024 guideline states that if there's a deepest vertical pocket difference of 4 centimeters or more between the 2 amniotic sacs in the second or third trimester, you must immediately increase ultrasound monitoring to at least weekly. You do not wait for full-blown TTTS criteria to be met. That 4 centimeter difference is your early warning siren. Okay, here is the definitive 2024 Delphi Consensus Criteria for Selective Growth Restriction, or SGR. You absolutely must commit this to memory for your exams. It's defined as an estimated fetal weight less than the third centile for one fetus, or two of the following three parameters: an EFU discordance greater than 25%, the smaller fetus having an EFW, or abdominal circumference, below the 10th centile, and an abnormal umbilical artery Doppler in the smaller fetus. See this? You refer to a fetal medicine unit immediately.
Section 4. Managing complex twin pathologies. Staging and intervention.
So, the Quintero staging for TTTS is vital for prognosis. Stage I is just the fluid discordance. Stage 2 means the donor's bladder is invisible. Stage 3 brings critically abnormal Dopplers. Stage 4 is hydrops fetalis, and Stage 5 is fetal demise. But here's the kicker. Disease progression can be wildly unpredictable. A pregnancy can jump straight from Stage I to Stage 3 without obviously passing through Stage 2. That is exactly why aggressive monitoring is so absolutely crucial.
When it comes to treating TTTS before 26 weeks, fetoscopic laser ablation is still the gold standard. But, and this is a massive 2024 update, the guideline explicitly mandates using the Solomon technique. It's a serial, sequential technique followed by equatorial laser dicoronization, and the evidence shows it significantly drops the recurrence of TTTS or post-op TAPS. There's also a strict quality control mandate now. Super-regional centers actually have to perform more than 15 of these procedures a year to ensure operators keep their skills razor sharp.
Now for SGR, your umbilical artery Dopplers are everything. Classifying it into type 1, 2, or 3 is exactly how you predict morbidity and decide when to intervene. Type 1, with positive diastolic velocities, usually has a pretty good outcome. Type 2, featuring absent or reversed end diastolic velocities, carries a very high risk of demise. But type 3, it's terrifying. It shows a cyclical or intermittent pattern, and it carries a 10 to 20% risk of sudden, unexpected fetal demise, even if the scan looked perfectly stable just days prior.
Section 5. Timing and mode of birth. Safe deliveries. Because of the inherent risks of a shared placenta, delivery timing is a massive balancing act. But for uncomplicated monochorionic diamniotic twins, meaning no TTTS, no SGR, no TAPS, 36 completed weeks is your magic number for a planned birth. The risk of continuing the pregnancy past that point just outweighs the risks of mild prematurity.
Interestingly enough, even if the pregnancy was complicated by severe TTS, but was successfully treated with fetoscopic laser ablation, your target delivery actually remains 36 weeks. The perinatal mortality after 32 weeks in these treated cases appears low enough that we can safely aim for that 36-week mark, assuming, of course, that weekly surveillance shows no further complications.
Severe SGR, however, is a totally different beast, and we have to act earlier. Type I gets delivered between 34 and roughly 36 weeks. But those highly dangerous Type 2 and Type 3 cases, you've got to plan for birth by 32 weeks, using ductus venosus Doppler waveforms or CTG short-term variation to optimize the exact timing. And crucially, you have to prospectively inform parents that despite our absolute best monitoring, sudden, unpreventable transfusional events can still happen. Complete transparency is paramount.
So, as we wrap up this explainer, I want you to think about how the mandatory Solomon technique for TTS, the strict introduction of MCA PSV screening at 20 weeks for TAPS, and those brand new Delphi consensus criteria for SGR are going to transform your clinical approach. These aren't just academic guidelines. They are powerful, practice-changing tools designed to protect the most complex pregnancies on your ward. The real question is, MRCOG candidates and clinical veterans, how are you going to integrate these new rules to change a patient's outcome on your very next shift?